Connect broadcast now. Okay.
Okay. So colleagues, welcome. Thank you very much for joining us for this fourth COVID-19 webinar from the Usher Institute at the University of Edinburgh. My name is Linda Bauld. I'm a professor of public health at the Usher. We had set up this webinar series. Those of you that have joined us before will know, really to provide the latest evidence from experts around the world on actionable insights that can inform government, policy, practice, as we all respond to this pandemic. And as you'll know, the World Health Organization has said there are now over 2 million cases. Some countries are shifting and releasing their populations from some of the public health measures that have been applied, and others are still very much focusing on trying to reduce cases and people who become ill and deaths. But for today, I'm really delighted that we are able to hear the experience of Hong Kong. And just to remind you of the process, we won't be able to see you, but please do compose your questions as the webinar proceeds and post them in the Q&A panel, not in the chat box that you'll see at the bottom of Zoom. And then I will try and choose the questions. We often get some that are very similar and ask them to Professor Cowling, who's our speaker. And the webinar is being recorded and it's also being live streamed on YouTube if you want to go back and look at it later. And I will say something about the next events in the series at the end. Just before I introduce our speaker, to thank Professor Aziz Sheikh, our director, who established this webinar series, and also the Usher communications team, particularly Jess Conway and Susan Buckingham. So I'm delighted now to hand over to Professor Ben Cowling, who's going to talk about public health measures to slow the spread of COVID-19 in Hong Kong. He's head of the World Health Organization Collaborating Center for Infectious Disease Epidemiology and Control in the School of Public Health at the University of Hong Kong. So over to you, Ben.
Thank you very much. Can you hear me okay?
Yeah.
Great. Let me put myself on a full screen. Looks okay?
Yeah, that's
great.
Perfect. Yeah.
Great. Thank you for the introduction. So I'm happy to share some observations on COVID-19 from our team in Hong Kong. I'll start just briefly talking about what happened in China and the impact of lockdowns. And then I'll talk a little bit more in detail about what's happened in Hong Kong, how we've been successful in suppressing community transmission of COVID-19. I'll make some specific comments on face masks because that's a controversial topic which my team has contributed to the evidence base on. And then I'll finish with a few conclusions. Introducing myself, I have a PhD in statistics from the University of Warwick in 2003, and I moved to Hong Kong soon after that in 2004. That was after SARS, when the Hong Kong government decided it wanted to invest more in emerging infectious disease capacity, particularly research capacity, to respond to the next SARS. And so I find myself here now, 16 years later, ready to respond to the next SARS. I've been doing research for the past 16 years in infectious disease epidemiology, including research in community-based studies of influenza mainly, other respiratory infections, looking at transmission dynamics, looking at disease burden and disease impact, and then also the effectiveness of control measures, particularly flu vaccines. Some of the earliest work that I did for COVID-19 is shown on the right-hand side of this. It was a paper in New England Journal of Medicine, and there was a note just published in NEJM by Gabriel Leung, myself, and a colleague, Joe Wu, describing how this came about, that we were able to work together with China CDC and within a space of just a few days, analyze the dynamics of COVID-19 in December and January in Wuhan and see what was going on. The plot in the top left, I'm very happy with because it's one of the few times I've actually used my own computer to generate a figure. Quite often, I will ask colleagues to help to do some analyses and rarely use the software myself to do statistical analysis, although I'm a statistician by training. But this one is one I did on my own computer on the night of the 23rd of January. So that's the incubation period, showing average 5 days, going up to maybe 14 days, 95th percentile. And that's really important for setting quarantine periods. The most important finding from that early paper in the New England Journal of Medicine was the reproductive number. Now, if you look at the figure on the screen, we had the earliest 425 cases in Wuhan, some of which were linked to the seafood market, and that's in the dark orange, others which were not linked. And what we looked at was particularly in December, before there was increased testing, increased awareness, there was evidence of slow exponential growth with a doubling time of about 7 days. And that corresponded to a reproductive number of about 2.2 if we use a serial interval of 7.5 days. Actually, that serial interval was not estimated particularly precisely. And if we use a shorter serial interval that we're now more comfortable with, actually the reproductive number, the R0, comes down a little bit more like 2 or a little bit below 2. And you can see from this figure the number of interventions which were done in Wuhan already in January. And then, of course, just off to the right-hand side of this figure on the 22nd of January is when Wuhan was locked down. And so there was massive extreme social distancing and also a cordon sanitaire around Wuhan to stop any more people from leaving that city. Although the exponential growth in December was small, it brings to mind the anecdote about the king and the sage in India, where the sage was challenged by the king to play chess, accepted the king's challenge, and the king said you could have any reward you like if you win. And so the sage modestly asked for a few grains of rice, a single grain of rice on the first square, and then doubling it on every subsequent square. So you can see the chessboard, first square 1, second square 2, then 4, then 8, then 16, then 32. And then fairly soon, there's too much rice to fit on the board. And it reminds me of what we saw happening in Wuhan, where in the early days, there really were just small numbers of cases, but with this exponential growth that now has reached millions and millions of cases worldwide. Recently in the news, we heard that the case numbers had doubled from 1 million to 2 million in the space of about 10 days. A doubling time of 10 days is not much longer than what we estimated in Wuhan of about 7 days without any interventions and control measures. Shows that it's really difficult to slow down COVID-19. I want to make a brief comment before going on about confirmed cases and what's the idea of confirmed cases. There's a lot of confusion often about why some countries have more cases than others when they might be not as badly affected. Some countries focus their testing on more severe patients. Others have a maybe broader availability of tests and are able to pick up a greater proportion of infections as cases. In fact, there will always be more infected people than there are cases. And that's because there's 4 things that need to happen in order for an infected person to become a confirmed case. Most likely they need to develop symptoms, and then they need to go and see a doctor or go to the hospital. They need to get tested by the doctor or at the hospital, and then the test result has to come back positive. And each of those steps is like a filter. So some people who are infected won't develop symptoms. Some people with symptoms won't go to the doctor. Some people who see the doctor won't get tested. Maybe the doctor won't order the test, or the test isn't available. And then even among the people who are infected, who do get tested, we know that sometimes the test can come back negative. And when the test is repeated a few times, then it might be positive. The caveat to that is, of course, that if people are under close observation, or if they're being tested regardless of symptoms, then we may find people who are PCR positive for SARS-CoV-2 without having symptoms and without necessarily having gone to see a doctor themselves. Maybe they're being monitored proactively for infection. But each of those 4 steps can lead to a reduction in the proportion of infected persons that are identified and classified as cases. So one of my recent projects has been a very detailed look at what was happening in Wuhan in the early stage of the epidemic, because there was a number of changes to the case definition used in Wuhan, which affected the pattern in confirmed cases. And if that pattern's ignored, then there's differences in how growth rates and reproductive numbers end up being estimated. So the figure here is accepted for publication in a Lancet series journal, should be coming out next week. The preprint is on medRxiv. I have the full link on the next slide. We looked at the first 7 case definitions that were used in Wuhan, and particularly how they were broadened over time to allow for patients with milder symptoms. So in order for a person to be able to be classified as a COVID-19 case in the first case definition, the first version, that's the first column, they need to either have a link to Wuhan or wet markets in Wuhan, some epidemiological link. So they need that. They also need all 4 of the clinical manifestations. So all 4 of the blue bars. They need a fever. They need a low white blood cell count or something else, evidence of leukopenia. Thirdly, they need radiographic evidence of pneumonia. And fourthly, they need to have failed antibiotic treatment, not improved their condition after 3 days of antibiotic treatment. And the last step, they need a whole genome sequence, which is identical to SARS-CoV-2, to their reference strain. So in order to be a confirmed case in the first version of the case definition, a patient would have to satisfy all 6 things: an epidemiological link, 4 clinical manifestations, all met, and also the sequence confirmation. As time went on, this case definition was broadened. By the time we get to version 5, actually cases can be confirmed either with 1 epidemiological link and 2 clinical manifestations and PCR positive, or no epidemiological link to Wuhan, but 3 clinical manifestations. That would be okay. And so that can capture a lot of mild cases that weren't being captured by the earlier case definitions. And of course, now there's even an 8th version of the case definition. It hasn't changed a lot, but there is even more case definition changes now. What's the implication of that? So we looked at it, and what we found is that every time the case definition changed, there was a jump in the proportion of cases that were identified, and it was noticeable. It was probably an 8-fold increase by the 5th case definition compared to the 1st. And when we plug in what could have been missed because of the early focus on severe cases, we see here, this is the orange curves in this figure. Quite a lot of infections were missed. And that's not a criticism of how things were being done in China, because actually in the United Kingdom, testing is mostly reserved for severe cases, not for mild cases. So what we're doing here is just estimating what the milder cases, what the numbers might have looked like, because if we don't do that, we get the wrong estimate of how fast the epidemic was growing, and we get an estimate of the reproductive rate that's rather high. You may have seen a number of publications recently with quite high estimates of reproductive number, 4 or even 5. And those are affected by this particular bias, where if you don't allow for the change in case definitions, you do get apparent rapid growth, which is not actually real rapid growth. Okay, I'm going to get on to Hong Kong in a moment. I want to first clarify the 2 kind of strategies that we think about when we think about mitigating a pandemic or a severe epidemic. The first one is containment, now called suppression by some. In containment strategy, we are okay with sporadic infections. We probably can't prevent every single infection, but our objective is to keep the number of cases at a low level, have as few cases as we can, understanding that we probably won't have 0 cases, we'll just have hopefully a small number. And the strategy to achieve suppression has 2 facets. The first is case-based approach, and the second is social distancing and community measures. For the case-based approach, we'll have to do a lot of laboratory testing, identify cases as early as possible, isolate them so they can't transmit onwards, and understanding that they may have already transmitted infection by the time we detect them. We also need to trace their close contacts who may have already been infected and place them in quarantine so that if they actually have been infected, they won't be able to spread infection any further. And that's really an essential component of the whole test and trace process. And then we'll also have most likely some degree of social distancing to reduce silent transmission in the community, by which I mean reduce transmission from infected persons that we haven't identified as infected, or the public health authorities haven't identified as infected, but may still be able to spread in the community. The problem with containment is very difficult to sustain such an effort, doing a lot of testing, a lot of contact tracing, a lot of quarantine, enforcing all of that, and also the social mixing interventions also have a real significant social and economic impact. On the other side of the table is mitigation, and that's once local transmission begins, we would prefer that it didn't overwhelm our healthcare system, so we try to spread out infections over a longer period of time, maybe more through social distancing, because when case numbers go higher and higher, it's more difficult to do contact tracing. We can still do isolation of sick people, but it's more difficult to do the tracing and then the quarantine of contacts. So we'll try and slow things down. There's major social economic costs of mitigation measures as well, and they'll be most effective if they're timed really precisely. So this is the concept of mitigation. And part of this figure is taken from a report that I helped the World Health Organization with in mitigating influenza epidemics and pandemics that was published last year. And so it just illustrates the concept that if our outbreak is like the green curve without any intervention, we'd like to slow down transmission, spread it out over a longer period of time so that there's less of a surge to the healthcare system. I don't think it's reasonable to expect that we will keep the blue curve entirely below the capacity of the health system, because many health systems are already operating very close to capacity anyway. But at least we can spare some capacity, maybe by postponing elective surgeries, maybe doing some other administered procedures, so we can make some capacity available, and we can also spread the blue curve out longer so there's less effect, a lesser part of the curve in excess of the health system capacity. Early on in the COVID-19 pandemic, there was a lot of discussion about whether we should go for containment, whether we should go for mitigation. And I distinctly remember, particularly in the United Kingdom, discussions about the plan to do mitigation, to slow it down as much as possible, protect the vulnerable during the peak, but then ultimately experience an epidemic like the blue one shown here, where there's a little bit of an excess above the health system capacity, but then it's all over by September and things can go back to normal by September. The problem is that when we crunch the numbers on what might happen with COVID-19, it looks more like this. The health system capacity is really much closer to the y-axis than in my previous diagram, and even a mitigated epidemic, even a blue curve, would overwhelm a health system in the UK, in Europe, anywhere else. And we've seen that happen in a number of locations already, starting with Wuhan, actually. And so spreading out the case over a longer time period, there'd still be a lot of health impact. And so countries, including the UK, went back to think more carefully about whether to really go for mitigation or to change plan and go for containment and suppression instead, because having an epidemic like the blue curve shown here would be have such an impact to health, to public health. Some of the information that was used by the modelers at Imperial College London to identify that substantial health impact, we'd also done some similar analyses here in Hong Kong, and my colleague Joe Wu published this paper in Nature Medicine that I helped a little bit with, showing estimates of the symptomatic case fatality risk based on a numerator, which was incidence of fatal cases in Wuhan by 20th February. And actually today, the numbers of deaths in Wuhan have just been updated. They've been inflated by about 50% because a number of deaths were found that weren't recorded earlier. So if those deaths occurred in the time period of this study, then actually the symptomatic case fatality risk would be even a little bit higher than shown in this paper. And for the denominator, we didn't use the case numbers in China. Instead, we used the international detections of COVID in Thailand, Japan, other places, because that gives a window into how many cases there must have been in Wuhan, including even the mild cases. And also we used data on prevalence of infections in repatriation of people from Wuhan to other parts of the world. And so the overall symptomatic CFR was 1.4%, which is really very worrying. Even if you have an asymptomatic fraction, still a symptomatic CFR around about 1% is an enormous CFR compared to something like flu. And we've seen the health impact of COVID-19 substantially exceed the health impact of flu seasons in places that are heavily affected. I looked at Financial Times to see an updated version of this plot that's been available for some weeks now, but I couldn't find it. This is the version on March the 28th that I saved. And I like to keep it because it shows Hong Kong and Singapore down here doing quite well in terms of slowing down the growth in cases, as opposed to the well-trodden path of many other countries, many other parts of the world, with doubling times every maybe 3 days, maybe every 4 days. There were increases in testing over this period of time that would have made incidents look to be doubling faster than perhaps it actually was, but still doubling every 3 days, every 4 days is really rapid doubling. How did Hong Kong and Singapore, and to some extent Japan and also South Korea, how did these places manage to slow down transmission so well? So that's what I'm coming to next. I wrote one of my first lay articles for the New York Times with one of my students here, which I'm very happy with actually, about some of the detailed measures that were used in Singapore, Taiwan, and Hong Kong. In Hong Kong, we have now just over 1,000 cases, and the last few days we've had very small numbers of cases. In the early days of the epidemic, we had imported infections from China, particularly from Wuhan. Those are shown in the blue bars on the left-hand side of this figure. So the blue ones are the imported cases. The yellow ones are called possibly local cases. Those are cases with some travel history, but not covering the entire incubation period. So it's someone who might have been infected in China, might have been infected locally. And so actually the earliest yellow bars are most likely also imported infections. There was some spread into the community, a couple of outbreaks that were notable, relatively larger, with probably 10 or more cases, but relatively quiet through January and February. And then things really heated up a bit in Hong Kong, starting in early March, when we had a lot of importations in people returning to Hong Kong or traveling to Hong Kong from Europe, also the US and some other parts of the world. And so the blue bars on the right-hand side of this figure, all the imported cases in pretty much in March. And remember, the yellow ones are also mostly imported. So we can think if we add blue and yellow together, that's really the majority of infections in Hong Kong are actually imported in, the majority that we've detected. And then there's some local spread and a few larger outbreaks in Hong Kong in March. How have we managed to contain COVID-19 so successfully? We've done a lot of testing. Now we're testing more than 3,500 samples some days, and that's in our population of 7 million people. So we're testing inpatients, we're testing outpatients with symptoms. We're even testing people that are close contacts of known cases in quarantine, and everybody who comes into the airport is now tested on arrival as well. Not very many, so we can manage to have the capacity to do that. So we're testing a lot. And then anyone who's found to be a case, even the mild cases, are isolated in hospitals, because after SARS in Hong Kong, we constructed more than 1,000 negative pressure beds. We have 40,000 hospital beds in Hong Kong, and more than 1,000 of them are negative pressure rooms. Negative pressure, either single rooms or small rooms with multiple beds that are negative pressure. And our public health authorities are very good at contact tracing. And then we have special facilities for quarantine of close contacts. We have holiday camps and housing estates that have just been constructed and not yet open to the future residents. So they're being used temporarily to house people under quarantine who've got a higher risk of being infected. We've also done quite a bit of social distancing. We have school closures since early February. So that's now in the 10th week. We have a lot of people working from home, and civil servants particularly have been instructed to work from home. A lot of other companies have work from home policies. We've cancelled mass gatherings. We've recently have restrictions on restaurant occupancy. So tables can have no more than 4 people at a table, and a restaurant cannot be more than 50% full at any time. Bars are closed, and people's behaviors have changed. I'll show that in a moment on another slide. People's behaviors have changed as well. There's a lot of memories of SARS, and Hong Kong people have a lot of experience with emerging infections, well-educated, understand what they can do to protect themselves. And we've seen quite substantial changes in behavior. And then in addition to the social distancing, we also have temperature screening at restaurants by law now, and many offices will have temperature screening. So my record is having my temperature checked 10 times one of the days last week, 10 times in a day, just because I went to so many different places that were doing temperature checks. In the note that was just published in New England Journal of Medicine, we show a timeline of all of these different measures that have been implemented. That's really a lot of detail in that slide. I don't want to go through every part of it, but I will highlight for the travel-related measures. Initially, we had restrictions from mainland China and then South Korea because there was a lot of cases there, and then expanded to Iran and Italy, other parts of Europe. And then from the end of March, from I think the 26th or 27th of March, we barred non-Hong Kong residents from outside of China to come to Hong Kong. So we have no more visitors to Hong Kong for the last few weeks. The only people that are coming into Hong Kong are Hong Kong residents returning from overseas, or people from mainland China, Macau, or Taiwan who haven't been to any other overseas countries in the past 14 days. And then everybody who comes in during this most recent period, the last few weeks, has to undergo a 14-day mandatory home quarantine. Mandatory home quarantine for 14 days. The rest of this slide lists the case-based measures and the social distancing measures as well. So you can see, particularly later in March, we did quite a lot of extra measures to get on top of the local transmission that had been occurring, driven by leakage from the imported cases into the community. So I got some data on voluntary changes in behavior from a number of telephone surveys that my team have been doing since the early days of COVID-19. We've been doing these in SARS, in pandemic flu, during H7N9 in China, and now in COVID-19. So we've got a good historical reference point for a lot of these things. I want to highlight just a few of the rows in this table. For avoiding, the first row, avoid going to crowded places, was 61% in January. And this was around the time that Wuhan was placed under lockdown. So it was still early days in COVID-19. It was also the time that the World Health Organization had their first emergency meeting about the public health emergency of international concern, decided not to issue it at that point in time. And so there was still uncertainty about to what extent was infection going to spread to Hong Kong, other places. Not completely clear, but there had been cases identified outside of mainland China by that point. So 61% of people had already changed their behavior to avoid going to crowded places. And that was up to 90% in February, 85 in March, again, 92 at the end of March. And that's when there had been a lot of imported cases recently. The third row is of particular interest to me because I have a special research interest in face masks, which I'll show some more on in a bit. By 21st to 23rd of January, already 75% of people were wearing face masks in public, and that's up to 98%, 99% in February and March. And the reference points for this in SARS, if I remember correctly, it was about 70 to 80%. In pandemic H1N1, it was like 10%, really not so much concern. But now here we are in COVID-19 with almost universal use of face masks in public in Hong Kong. People wear it on the underground, they wear it on the street, they wear it in their office. The only place they don't really wear it is at home and when they're out at a restaurant eating. Hong Kong's got a lot of experience with school closures. So in the last 15 years, I think we closed schools 4 or 5 times for influenza, once in the pandemic, and also 3 times for seasonal flu epidemics that were relatively more serious. So we have a lot of experience in handling school closures, although they're not normally for that long. Last year, we had a 2-week closure. Now we're into our 10th week of school closures. Most families where there are 2 working parents in Hong Kong will either have live-in domestic helpers from Southeast Asia, or will have family support, for example, grandparents to help with the children. So it's not having as much impact in Hong Kong as it would, for example, in the United Kingdom. So school closures are more feasible perhaps in Hong Kong because of the availability here of support for childcare and so on. And there's a lot of local support for school closures. In our surveys in February and March, we asked the respondents who were parents if they agreed or strongly agreed that school closure was needed. And that was 95%, 94% agreed that it was needed as a control measure. Actually, I think the data's still a little bit unclear on how important school closures are for COVID-19. We know that children can get infected. We've seen deaths, unfortunately, in a small number of children, but we haven't seen large outbreaks in schools, in places where schools have remained open. We haven't seen a lot of teachers getting infected, to my knowledge. So it may be that schools are not as essential to COVID-19 transmission as they are really a driver for influenza transmission. And the third point in this slide, just to confirm, a common question for school closures is whether children really stay at home, but actually in Hong Kong, they do. 80% in February, 69% in March. Parents responded that their children had no contact with people other than their household members on the preceding day, mostly staying at home. And even if they do go out, they don't have a lot of other contacts. They don't certainly have as many contacts as they would have had if they were going to school with all their classmates and teachers and lunch breaks and so on. We looked at the change in influenza activity in Hong Kong associated with all of the measures that were implemented for COVID-19 that I showed a few slides ago. All of those social distancing measures probably had an effect on COVID-19 transmission in the community, we would hope, but they also had a drastic effect on influenza transmission. So we were having an H1N1 season, it was going up towards Chinese New Year, and then the end of January, Chinese New Year, that's when all the public health measures started, and we saw a very rapid drop in influenza transmission, a 44% reduction in transmission, which is the biggest we've ever seen. In typical other flu seasons, when we've had school closures, the reduction was about 15%, maybe 20% in transmission. So that's a much more substantial reduction this year. It means that the behavioral changes, maybe the hygiene improvements, maybe a small effect of face masks, maybe other things have all contributed to reducing influenza transmission and probably also reduced COVID transmission, of course, not by 44%, but reduced COVID-19 transmission by some measure. This is in previous years, just for comparison. So the left-hand side is 2020, the right-hand side 2010, 11, and 2014, 15. We see a much smaller drop in transmission in the school holiday periods compared to what was happening before the holidays. And the Chinese New Year period is odd because there's a lot of changes in social mixing for that one week holiday, 7 to 10 day holiday. I want to touch briefly now on face masks, coming to the last quarter of my presentation. How do respiratory infections spread? There's a lot of discussion about the different modes of transmission, droplets and contact transmission by fomites. So a diagram here in a study that I was involved with a few years ago, looking at how different respiratory pathogens spread. And I want to highlight one very important observation, which is sometimes missed. If you look at the person on the left who's in red, who's the source, the infected person, and the person that's facing them quite close, if infection is going to occur to that contact, the close contact, it could be by large droplets. It could also be by short-range aerosols, where there'll be a higher concentration of virus in aerosols if there was any virus in the aerosols. And so we don't see for COVID-19 long-range airborne route, long-range airborne transmission, which is the person on the right-hand side of this figure. There's very little evidence, not really documentation of long-range airborne transmission. That doesn't mean that aerosols aren't contributing to transmission, because it could also be explained if the person in red on the left-hand side, the source, is not actually that contagious. So if they're not emitting that much virus into the environment, maybe some virus in large droplets, maybe some virus in small aerosols, there's a higher concentration at close range. So with prolonged close contact, there's the opportunity for transmission to occur. But at longer range, the concentration of aerosols would really be very low because of dilution by ventilation and inactivation as the virus stays in the air for longer. Maybe ultraviolet light could help. Maybe environmental conditions could help to deactivate some of the virus, to inactivate some of the virus. So just because we don't see long-range airborne transmission doesn't mean that aerosols can't play a role in transmission of something like COVID-19. I think there's a distinction between the degree of contagiousness and the droplet sizes that are involved in transmission. Certainly COVID does not spread like measles, in which long-range transmission is possible, but we know that measles patients are highly contagious. So they're highly contagious at close range, and they're still contagious for people at longer range. For COVID-19, people are not very contagious. Reproductive number of 2.2 indicates that in general, cases of COVID-19 are not very contagious to others around them. You really need a prolonged close contact. So what's the implication for face masks? Three, broadly speaking, categories of face masks. On the left, the cloth masks, where there's very little empirical research on their effectiveness in community settings, particularly in reducing infections. There is quite a bit of research in laboratories on filtration, performance, and so on. relatively less on how well they actually prevent transmission. And that's actually an important gap I think should be filled in the coming years. That'd be a really important area to do research on. In the middle are the surgical masks, typically with 3 layers. And there's some evidence base for these, but obviously we have limited supplies of surgical masks now. So we're restricting those mostly for healthcare settings. In Hong Kong, it's common to see people wearing surgical masks on the street. And also many people are wearing cloth masks because we don't have enough surgical masks for everybody. And on the right-hand side are the respirators that really should just be restricted for use in healthcare settings with higher filtration performance, no leakage. And so they can really stop even aerosols with the virus in from getting through to the person who's wearing them. But they're very difficult to wear for long periods and not really suitable for community use. So over the past some number of years, we've been doing a study in Hong Kong that's really a difficult study. We worked together with Don Milton from the University of Maryland, who designed this machine. The idea of the machine, the concept is the person with viral infection, maybe influenza, sits in the machine with their head in the cone. You can see the picture on the right-hand side, sit there for 30 minutes. And the machine is designed in such a way that it sucks in all the air that's breathed out or coughed out by the patient for that 30 minutes and is separated into 2 fractions. The coarse fraction, larger than about 5 microns, is stopped at the end of the funnel. At the end of the cone, there's a impactor to catch the larger droplets. And then we sample those and test them to see what amount of virus was in them. And then the rest of the air goes through into a chiller and a condenser and is dropped into a reservoir, which we can then extract. And the infectivity is preserved in that component of the exhale breath, in the fine fraction, which is the aerosols. So we could actually culture the virus if we wanted to, if we detected virus in the aerosols. So Don Milton had been studying influenza. We also did a study on influenza going back to 2013. But then we broadened the study. So we wanted to look at other respiratory viruses as well, not just influenza. And what did we find? Well, firstly, the results for influenza. So I'm showing here some results from the machine. The points in the plot are the virus copies per sample. For the nasal swab, a lot of viral copies per sample. For the throat swab, a little bit less for influenza. And then the middle column highlighted with a red square are the large respiratory droplets bigger than 5 microns. For the patients who didn't wear a surgical mask, so we randomized patients to wear a mask or not wear a mask during the collection, and a small number provided a second sample of the opposite type. For those participants who did not wear a mask, some of them we were able to detect virus in the respiratory droplets. Many of them didn't have detectable virus in respiratory droplets during this 30-minute collection, and presumably not that contagious. The ones with virus in droplets would be a little bit more contagious. And for those who wore the face mask, the virus in the droplets was reduced substantially. There's a significant difference. On the right-hand side is the aerosols. Again, we found some influenza virus in the aerosols in some patients. Those could have been contagious. Other patients, really, we didn't find virus in the aerosols, perhaps less contagious. If we'd sampled for longer than 30 minutes, maybe we would have picked up some virus in the aerosols in those. We can't say that they didn't have any, just that there was a limit, that there was an amount below our limit of detection. And on the right-hand side is the aerosols in the patients who wore the mask, and there was no significant reduction. So the surgical mask worn by flu patients blocked respiratory droplets with the virus in, but didn't have a significant effect on aerosols. Although work by Don Milton, published in PLOS Pathogens a few years ago, found that there was a reduction in aerosols that was significant in his study, but it was less of a reduction in aerosols than the degree of reduction in respiratory droplets. Interestingly, in the patients with human coronaviruses, that's common cold coronaviruses, we also found the same phenomenon. Most or majority of the participants, we couldn't find virus in the exhale breath in that 30-minute collection, maybe not that contagious. Some of them we did. And for the face mask, marginally significant reduction in respiratory droplets. And on the right-hand side, a significant reduction in seasonal coronavirus in the aerosols. So that's interesting. I mean, the numbers are small, but it does indicate that masks would be quite useful for source control if they're worn by people with infection. And in a recent study, which I didn't have time to include here, we did look at pre-symptomatic transmission, and there is quite substantial evidence of pre-symptomatic transmission. We looked in China, and we estimated that in the context of public health measures to isolate cases, in some cases soon after symptom onset, maybe 44% or so of transmission could have occurred before symptoms appeared. So that was published in Nature Medicine a few days ago. So to summarize on face masks, and then I'm going to wrap up to leave some time for questions. I think we have evidence now from randomized trials of face masks in the community that face masks don't have a substantial effect on transmission in the community. If they did have a really substantial transmission, so if they really did have a, let me start again. If face masks had a really substantial effect on respiratory virus transmission, it would have shown up in the randomized trials that were done with limited compliance in some cases, with other caveats. Even so, if face masks were really, really brilliant, I think we would have noticed in those RCTs that are done. But what we haven't been able to establish is whether there's a small or perhaps even a moderate effect on transmission that was too small to be picked up by those trials, even by the meta-analyses. And a recent meta-analysis was published by my group in Emerging Infectious Diseases. So although we don't have evidence that they do have a substantial effect, absence of evidence is not the same as evidence of absence. And there could be an effect. We presume there's an effect of surgical masks because we do recommend their use for healthcare professionals as part of droplet precautions. And the WHO guidelines that I was involved in, that I mentioned earlier, we did mention in that in the next influenza pandemic or severe influenza epidemic, if it's really, really severe, then countries are going to think about using everything at their everything that they can to combat transmission, to slow down transmission, and universal face masks could contribute to that. But of course, if supplies are available, and the number one priority is having enough supplies for healthcare workers, of course. So in Hong Kong, we've thought about what would be the rational use of masks. I think sometimes masks are overused here, but at least they need to be worn properly. At least we could wear masks in crowded areas, on public transport, and particularly for people who might have been exposed. If they're in quarantine, they need to leave their home for some reason, they should really be wearing a mask as a way of source control. A critical thing to remember with masks is they need to be worn properly. And I was amused when I saw this photo in an article in Science magazine on the right-hand side, because we can see surgical masks with the straps undone, N95 respirators being used outdoors in the community, scarf not covering the nose, and so on. So I think there's a public health education requirements if masks were to be recommended. And I know in the UK, they're not currently recommended in the community. In Hong Kong, we've had a lot of public education about the right ways to wear face masks, the right way to handle them as well, take them off, wash your hands, dispose of them, to avoid being infected by the mask that was giving you some benefit. So what's the current situation in Hong Kong? I've got just a few more slides. We've been monitoring the reproductive number over time. It's been about 1 for 10 weeks, and it's now dropped below 1 because the last few days we've really had very small numbers of cases, and we don't think we're missing a lot because we're doing so much testing in outpatient clinics and in hospitals, and also in people coming into Hong Kong, as I mentioned. We managed to shorten our onset to reporting intervals, but I got an important point to make here. So this slide shows a red dot for every case in Hong Kong that's an unlinked local case. So this is a case in the community. We don't know how they got infected. We can't explain their infection based on any of the other infections that we know about, the other cases we know about. In the early days of the epidemic, it was taking more than a week to pick up these cases, but we've brought that down substantially. Now it's typically just a few days towards the end of March and in April. But obviously, given that people are most infectious around the time of symptoms, and even a little bit before symptoms, there's still opportunities for transmission to occur from these cases. And that emphasizes the importance of contact tracing and quarantine in order to suppress transmission. Currently at our border, as I mentioned earlier, visitors are not permitted. Inbound travelers have mandatory 14-day quarantine. We have a saliva sample on arrival, which is tested for COVID-19. And we have very few arrivals these days. This week it's been about 500 arrivals per day in Hong Kong Airport, which is one of the major international hubs in Asia. 200,000 people a day last year, 500 a day this week. When will it go away? That's a question that journalists keep asking me. I don't think it will go away. I mean, we would like it to, but I think it's going to be difficult to get rid of it unless we really have a very effective vaccine that's used everywhere in the world. It's unlikely that the transmission is going to be suppressed by environmental conditions. It's spread around the world, and we expect epidemics in different parts of the world to continually reseed places that have got over their first waves, have managed to contain transmission. There's still going to be opportunities for infections to come back again and again and again. And we're seeing that now in China, where there's been importations of infections in the past few weeks, and certainly a threat of a resurgence in cases now that many of the measures have been lifted. If we could have an effective antiviral treatment, we'd be less concerned about the surge in cases and the overwhelming impact on healthcare. And I don't think a vaccine is going to be available in the short term. I hope it will be, but I don't think it will be. Our last slide, what's next in Hong Kong? We're going to continue suppression measures. We're still on the alert for surges in imported cases, although with only 500 travelers coming in a day, there's a limit to how many of those might be infected. And so we don't expect surges right now, but certainly in the future, if things change, we'll be ready again for another wave of infections. The social distancing measures that have been implemented might be tightened if there was an increase in local infections, and that has happened in March, might be relaxed if infections die down. We'll think about that in the next few weeks. And the border measures are going to continue for a while, because if we open up the borders again, we probably would have a lot more infections being brought into Hong Kong, and that would challenge the test and trace measures. So I'll finish with acknowledgements. People on the slide here, Gabriel Leung on the right-hand side, and Joe Wu Peng at the back, and Eric Lau and Kathy Leung particularly. That's really a key team here. And altogether, we have probably 30 or 40 people working on COVID at the moment, staff and students. We have a big team of people and diverted a lot of our resources with the support of our funding bodies, including the Health and Medical Research Fund. So I will end there and ready for some questions.
Thank you very much, Ben. That was really excellent. And I think all of us have learned a huge amount from that presentation. We've had a lot of questions. I'm going to start from the bottom and go back to face masks, if that is okay with you.
Yep.
So a couple of questions here, and I think we all appreciate your work on masks. This is a very live debate here. So first part of that is, which masks have been used by healthcare workers? And the second part is that the aerosol graph suggests higher density of the virus than in droplets, and where masks are less effective. Does this have implications for transmissibility in offices and restaurants? So you talked about a few settings, but thinking again about what might happen in the UK in the future, even if it's only a small added benefit, should we be thinking about those settings?
Yeah, okay, so that's a lot of questions. I'll try and remember, tell me if I missed one. So for the first question about healthcare settings, in Hong Kong, for wards where there's COVID-19 patients, it's airborne precautions, N95 respirators. In the rest of the hospital, it's a universal masking policy. So every patient and every staff member wears surgical masks. And we don't actually allow visitors at the moment, which is a bit, it's not ideal, but if there were visitors, they'd also have to wear surgical masks. And that's been a long-standing policy in hospitals in Hong Kong anyway, universal masking, or most people wearing masks, but it's really a universal use now. And then the second question was about contagiousness in aerosols versus droplets. I think it's difficult to say. We have small numbers in our study. This is the coronavirus slide. This is the influenza virus slide. It's difficult to judge because, I mean, what we really need is a slightly larger sample size and also a detailed model of aerosol dynamics, droplet dynamics, and considering how people might be exposed. If you're sitting face-to-face in a restaurant, that's quite different to sitting side by side. And we've seen transmission occur with both of those scenarios. So, I mean, in my opinion, for COVID-19, most likely short-range aerosols has a role to play, but we know most patients are not very contagious. So that explains why prolonged close contact has been one of the factors identified as linked with COVID-19. So does that answer everything?
Yeah, no, that's fine. We don't need to belabor the offices and restaurants, but that's good. So just to ask you another combined question, what proportion of the population, this kind of speaks to your last slides, do you think has been infected? And then secondly, any comments on nursing homes?
So we have had 1,000 confirmed cases in our population of 7 million. I expect we missed some, particularly mild cases, particularly in the earlier stages. Now we're doing such a lot of contact tracing and quarantine that we are picking up secondary cases that have occurred. I doubt we've got much more than between 1,000 and 2,000. So let me say again, I doubt we've got up to even 2,000 infections in Hong Kong. So seroprevalence, when we measure it, I expect will be very low at present, unless we've been missing something that's happening that we haven't noticed. So we still basically haven't had community epidemic, where we haven't even had a first wave. We've managed to prevent a first wave of infections.
Great. And any comments on nursing homes? Oh, I know that's...
Oh yeah, nursing homes. So I think nursing homes don't allow visitors now because we're worried about infections getting in, and we haven't had any outbreaks in nursing homes, fortunately, because that would be a big worry. And in Hong Kong, everybody lives close together. In nursing homes, everybody lives close together.
Yeah, so I think that's a big concern for us at the moment, where we're seeing a large number of cases there. So what about serum antibody tests? Again, that's a live debate across the globe. Is there a case for estimating population prevalence there, maybe in the future, regardless of the presence of symptoms?
So we're going to do that. My team is going to do it. We're still checking which of the assays would be the best ones to use. Maybe we'll use one assay for screening, and then we'll go to neutralization as well for confirmation. But we don't expect to find much evidence of community infection right now. What we do now is most likely get a baseline and then see how things change in the coming months.
Okay.
But certainly, I mean, there's a really important role of serological studies elsewhere in the world. I think in London, it'll be fascinating to see what serology shows up.
Great, and I look forward to your contributions on that. Now, a question on low and middle income countries. These, as you said, already have vastly overwhelmed healthcare systems. So what, in terms of the measures that you've imposed, or the government has, what do you think realistically we can do in LMICs?
I think it's really difficult in LMICs because things like lockdowns have an enormous impact when people need to go to work to do their jobs. For me, I can work at home, but many parts of the world, it's not possible for people to work at home in the same way. And so there's going to be enormous economic impacts, particularly in low and middle income countries, of more drastic social distancing measures. So I don't know, it's kind of really a big problem to figure out what would be the most appropriate measures that could either keep transmission at as low level as possible, or at least slow it down as long as possible and keep it down. I know that quite a number of countries in the region in Asia have been doing lockdowns, and I don't think those are sustainable.
No, I think it's going to be very difficult. Tell us a little bit more about the testing at the airport. Now, you talked about the quarantining of people, and you've only got 500 people coming in a day. But what's the regime there? And again, is that something we should be thinking about in the future? Because we've basically not done it. Yeah,
so what we saw in Hong Kong, if I can just put up that slide. What we saw in Hong Kong is a really heavy pressure from the imported cases and some limited transmission into Hong Kong from those importations. So on this slide, it's the darker shade at the top. Most detected cases were imported and there was leakage into the community. If we'd been having more and more imported cases, it would have really placed a heavy burden on test and trace. Social distancing probably would have still been able to keep it slower. We wouldn't have seen very rapid growth in cases, but we would have seen a community epidemic most likely. So now if you come into Hong Kong airport, if you're a Hong Kong resident, you need to go to the convention center that's next to the airport, provide a saliva sample, because in Hong Kong, they're really like doing saliva samples rather than nasal swabs. And that's taken away to the public health laboratory for testing. If you don't have symptoms, you're free to go, but you need to go home and do the home quarantine with the wristband, just like people get in the UK when they go on parole, when they're out of prison. You wear the wristband and it monitors where you are all the time. So we have that in Hong Kong for people who arrive. If you have symptoms when you arrive at the airport, a fever, coughing, then you need to wait at that convention center for your result to come back. And that can take many hours. I think there's reports of people staying at the airport 9 to 12 hours for those results. So that's requiring a lot of infrastructure. And I don't know for how long we can sustain that, just because Hong Kong's an international travel hub.
Yeah, and I guess this is a personal question for me. We've got so many international students, as you know. Do you expect these borders are largely going to remain closed and this international travel is going to be restricted for a very long time? Would that be your hunch?
Yeah, I'm worried about that because we have international students here as well. And I don't know what's the, it's difficult to look forward too far ahead. Certainly the border measures in Hong Kong are going to continue for a little while longer, at least until things have calmed down elsewhere in the world. But if they don't come, if the numbers of infections don't come down in some places, then it's going to be difficult to think about reopening. But there's an enormous part of the economy in Hong Kong is based around the airport, international trade, international travel. And so it's really having a damaging economic effect.
Yeah. And then just a couple of questions on testing. So just any comments on the sensitivity of different tests and the factors influencing that?
I'm not the right person to ask about that. I'm not involved in doing the sensitivity specificity, but some of my colleagues in the laboratory here are.
And did you know anything about, so this is without going into the details, this is a question from Harish. Did the tests used to screen patients in Wuhan change over time? And did their sensitivity and specificity change? So just looking back at those really interesting early changes in Wuhan.
Yeah, that's a good question. I don't know. I don't think so, but I don't know for sure. I know that in the very first case definition, the sequencing was required, and that was loosened after January the 18th. But in terms of the PCR diagnostics, I don't know what happened. I will tell you one thing though, that you may not know. So you've probably seen in the news that there was a hospital built in Wuhan with 1,000 or more beds in a space of 7 days. They got a lot of media coverage. But around the same time in Wuhan, they also built a brand new lab from scratch to test 10,000 samples a day. And that was done in about a week as well. So that was really an impressive measure that it gave them the capacity then to test lots and lots of people.
Okay, and then the last question, again, I'm trying to cobble together, I think, comments from a number of people here. So obviously our great anxiety in the UK, Ben, and you understand both country contexts, is, what are the next steps? And our government is reluctant for good reasons to discuss those at the moment. And a big topic here is schools. We had a systematic review, largely looking at SARS, that said that school closures were not, going to be the best thing or the most important thing you could do in terms of containment and mitigation. So in terms of thinking about what we could learn from Hong Kong for the UK, specifically also about schools, have you got any thoughts?
I think that looking at the evidence base of the effect of school closures on SARS is not that informative, because SARS transmission almost all occurred in hospitals, not in the community. So school closures didn't really have a noticeable effect on SARS, but that's because SARS wasn't spreading in schools anyway. When we look at the evidence based on school closures, there's a lot on flu, but COVID is not the same as flu. Children don't seem to be as important. So I would tend to think that school closures wouldn't have as much effect on COVID-19. Maybe some effect, but maybe the kind of effect that means they wouldn't be a critical intervention. That could be one of the first things to relax. And I'm aware that in some European countries, school closures are now being relaxed. So schools are now going back. And everyone is watching really carefully to see what might happen in those locations, because in Hong Kong, we'd like to reopen schools at some point as well.
Yeah, very important for our children and young adults, young people. Okay, I'm going to draw it to a close there. We only got 1 minute left. Is there anything you wanted to add, Ben? I'm just going to say something about the next webinars.
No, thanks. I'm happy to have a chance to share with everyone. Yeah. Thank you.
Well, that was really brilliant, and we will be sharing your slides as a PDF. So just to encourage colleagues to do go back to the live stream on YouTube if you didn't manage to catch all the detail, a lot of data there. So just as a final thing, to sincerely thank Ben Cowling, that was outstanding, and to flag our next 2 webinars. So please do join us on Friday the 24th next week at 9 a.m, where we'll be hearing from Professor Jerome Kim, talking importantly about South Korea's experience and also vaccines. And then after that, a colleague from Africa, Yodi Alagdia, who is really going to speak from a humanitarian perspective and was formerly the chief humanitarian coordinator in Nigeria. And then following that, we also have confirmed in the next week after that, a speaker, Dr. Tai from Vietnam. And colleagues will be aware that Vietnam has been so far fairly successful in terms of addressing COVID-19. So I hope those will be useful. We're still working hard on securing other webinar speakers, and very important that we can all share this information. But thank you to everybody for joining us, and thank you to Ben Cowling once again. I'll say goodbye.